students. Welcome to the second of a series of podcasts done by yours truly on diabetes. This one is entitled, What the Heck is Diabetic Ketoacidosis? By now you should be somewhat familiar with the polys, the three P's, polyuria, polyphagia, and polydipsia. Polyuria has to, Polyuria has to do with the increase in volume of urine as a result of glucose spilling over from the blood into the urine. That occurs when the blood sugar is greater than 180. The polyphagia refers to the cells not getting sugar, so they're hungry. So the patient also feels similarly hungry and has a strong propensity for eating. In addition, the polydipsia, mostly related to polyuria, is due to the absolute thirst that patients acquire as a result of this polyuria. And here's a graphic that I took either from Laney or Brunner that just sort of discusses again what we talked about in class today. Insulin deficiency is really the reason why we have diabetes, and then of course the end result of the massive hyperglycemia associated with diabetes type 1 is ketoacidosis. So it's largely due to a glucagon excess. Because glucose is not getting in the cells, glucagon comes on board to try to also provide some sort of rescue for fuel for the body. But without insulin, glucagon is not turned off, so glucagon runs unopposed. So what happens is I told you to look at this insulin deficiency or ketoacidosis in terms of protein, carbohydrates, and also fats, because that will help you to paint a picture of what actually occurs in ketoacidosis. So here we have glucose not being able to get inside the cell, so we look for fuel in other places, and largely we look to the muscle, and with the muscle we have now muscle wasting. I lost my pen, so I'm using my mouse to write with, which is not much fun, so I apologize. But we have muscle wasting, which then breaks down protein and leads to the accumulation of amino acids as a source of fuel in the blood. Then we also turn to the fat. Adipose tissue is broken down, which releases triglycerides and also free fatty acids as a source of sugar. And don't forget, your patients with diabetes have problems with triglycerides, so and ultimately fat metabolism. So once this DKA is actually resolved, some of that fat might be redeposited in unusual places in the body, and it leads to fat storage, which is a problem for many diabetics and reason they don't take their insulin to begin with. So back to diabetic ketoacidosis. So you have breakdown of adipose tissue, which results in elevation of triglycerides as a source of glucose for gluconeogenesis, and you also have formation of free fatty acids, which leads to ketone production. It probably is the ketone. Once you have the presence of ketones, that is a warning sign that your body's in crisis, that the blood sugar is definitely getting out of control, and the patient will need some sort of assistance in treating this, i.e. hydration and insulin. So you've got all these acids accumulated, amino acids, free fatty acids, so it leads to metabolic acidosis, and we'll talk more about that in a few minutes. But then we talked about protein, we talked about fat, so let's talk about carbohydrates. Whenever you have insulin deficiency in the face of carbohydrate management, you have increased gluconeogenesis from the liver, which leads to hyperglycemia, which leads to the osmotic diuresis, profound water and electrolyte loss, and ultimately dehydration. You should really be checking orthostatics on your patients with diabetes as a way to sort of get an indication of how much fluid loss they've actually succumbed to. Now remember, we did talk about autonomic neuropathy, and that with autonomic neuropathy in diabetics, they may drop their systolic blood pressure upon sitting just from their diabetes alone, not associated with dehydration. So it may or may not be useful in these folks, but I would encourage you to do so. And ultimately, if you don't correct this dehydration, this will lead into circulatory failure. So Metabolic acidosis. Ketoacidosis, diabetic ketoacidosis is a metabolic acidosis. Earlier this semester we talked about the respiratory illnesses and leading to respiratory acidosis and respiratory alkalosis. Here we have metabolic acidosis in the face of hyperglycemia. So I'm going to give you a moment to try to see if you can calculate out what the pH is, what the PaCO2 is, PaO2, and the bicarbonate in this case of metabolic acidosis. Good. I hope you got it. I hope you got it. So the pH here would be less than 7.35, right? Because it's an acidosis. So less than 7.35. Their PaCO2, now that should be normal at first, within normal limits at first, at the onslaught of this. PaO2 should also be within normal limits. This is not a respiratory condition. It's a metabolic problem. Since this is a metabolic acidosis, the problem here is that this is very, very low. It is definitely less than 22. Sometimes I've seen it even as low as 8. And a bicarbonate of like a pH of 7.20. So this is typically what happens with metabolic acidosis. Now eventually the lungs will try to get rid of some of that acid, and eventually the CO2 may drift down a little bit to try to accommodate. But typically it starts off with these being within normal limits. The lungs, remember, there's 3 systems that adjust to an acidotic or an alkalotic condition that regulate these systems. It's the lungs, the kidneys, and the cells. So here the lungs blow off CO2. In an attempt to blow off CO2 or acid, they have deep breaths, huge breaths. And what they're doing is trying to really have a big expiratory phase to blow off the acid, and the breath actually smells very, very sweet. It's classic. That's one of the first signs you'll see of diabetic ketoacidosis in a patient, is that they'll start taking these deep breaths, the 3 P's, and then the deep, deep swelling effect. And here you have your cells. They also help to regulate. In the instance of acidosis, you have increasing hydrogen ions accumulating in the blood. So the movement is into the cell at this point. I couldn't find a real cell, so I used a cell phone. So I thought it was kind of cute. At least it gets the point across. So hydrogen ions move inside the cell, and you have to have an exchange. So what comes out? Potassium comes out. So look for a pseudo-hyperkalemia in diabetic ketoacidosis or in any acidosis. Do we treat this? No, we generally don't. Find out what caused the diabetic ketoacidosis, treat the diabetic ketoacidosis, and within a short period of time, this will reset itself. Now the kidneys, remember, take as long as 8 hours to begin. They don't act right away. So you may have to wait about 8 hours for the kidneys to start to help correct your diabetic ketoacidosis. But the effect can last for days. And that's important because diabetic ketoacidosis is not cured in a day. It may take 2 or 3 days, depending on the patient's renal status, for them to come back to normal as a result of the kidney's compensatory mechanism. So this is a much longer duration, but it's a very effective corrective agent. So here the kidneys absorb sodium and bicarbonate from the blood, from what would be the urine, and create sodium bicarbonate and secrete it back into the peritubular capillaries. That's how the bicarb level will start to come back up. And the treatment for diabetic ketoacidosis is really largely, it should actually be reordered. It's water replacement, no doubt, because they're profoundly dehydrated, these patients. So number 1, start the fluids. Number 2 would be insulin, as evidenced by this R on the bag here. And remember, insulin is regular insulin, clear insulin, because you want it to work immediately. And we generally, because insulin can be so difficult, I mean, you can kill people with regular insulin in like no time sharp. So it's always a one-to-one relationship. So we generally put 50 units in 50 mLs to run at one-to-one relationship, so that you can always walk in the room immediately and see what the rate is and make sure that it's correct. You may or may not need to correct the potassium along the way. Again, just bear in mind that they may be low, they may be high. It's going to fluctuate quite a bit. Obviously, number 4 is regulation of the glucose levels by giving the insulin. Of course, you want to do a bunch of serial blood sugars afterwards and look for the correction of that. And then may or may not give bicarbonate for acidosis. But primarily, again, in review, water and sodium replacement, insulin replacement, clear insulin, may or may not replace sodium, look for your fluid and electrolyte management, and normalize glucose levels. So I hope you enjoyed this PowerPoint, and I'll look forward to seeing you on the next podcast series. Thank you very much. Bye now.